Hello guys, it's Meredith here again, and we're going to do a third case. This one's a little bit long, but it covers multiple topics, and so I'm hoping at the end of this you'll have a better understanding of the basic interpretations of PFTs. So here goes. Spirometry number 1. Let's look at the ratio. Here, it's lower than the lower limit of normal, and so we can say a decreased FEV1 to FVC ratio means airflow limitation. So you may also notice that the FVC numbers are red, so that's got to mean something. So let's look at the FVC. You can see here that it's also lower than the lower limit of normal. So a decreased FVC has its own differential diagnosis. Can you remember? So either the TLC is going to be low, and this is going to go along with restrictive process, or the TLC is actually going to be high, and this is going to be because you're having an increased RV actually, and you have hyperinflation and air trapping. So look at the lung volumes, easy enough. So the TLC in this patient is actually above the upper limit of normal. It's actually increased. So this person has high TLC. So what does that mean? Well, let's take a look at the RV. The RV is above the upper limit of normal quite significantly. And so remember, increased RV means air trapping. I also want to point out this RV to TLC ratio, which in this patient is increased. And this is just further evidence that this person probably has some sort of small airways disease going on, which is again consistent with your diagnosis of airflow limitation. All right, so number 3, we always want to look at diffusion. And so looking at the DLCO in this patient, it looks to be significantly below the lower limit of normal. So remember, a decrease in DLCO is a diffusion issue. Differential is either at the alveolar level or the capillary level. But could it be both? If you think about emphysema and alveolar destruction and how the alveoli are all sort of encased in this capillary bed, yeah, you can get destruction of your alveoli and your capillary bed simultaneously. All right, so now this bronchodilator thing. I've been avoiding it, but we probably have to talk about it. So basically, you get an inhaler and you take a couple puffs and then you repeat your spirometry and compare it to the spirometry pre-bronchodilator. So what you want to compare is the pre-bronchodilator, post-bronchodilator. You want to look at the percentages and you want to look at the volumes. And this is for the FEV1 and the FVC. So the rules here are that either one needs to be increased by 12% and increased by 200 cc's. So here, the FEV1 is 1.2 liters, and subtract the prior FEV1 of 0.84 liters, and you get 180. The FVC, on the other hand, is 1800 minus 1510, and so that comes out to be 290, which is greater than 200, and so you've met your goal. So next we just need to look at the percent change, and this person clearly met the over 12% mark. So they got 290 plus greater than 12%, so check, they have a positive bronchodilator response. But why do we do it? We mainly do it because it can help us distinguish between things like emphysema and asthma. It doesn't change our treatment. All right, so now that that's explained, let's go back to the case. Let's start back at the flow volume loop. So you can always use your flow volume loop to sort of confirm what you're thinking. So there's a normal person, and then here is the patient that we're looking at. So that's very much consistent with an airflow limitation. And again, if I haven't convinced you yet, remember this prolonged expiratory phase is a key finding in these patients. So this would be, again, consistent with airflow limitation, which you've already proven to yourself by the FEV1 to FVC ratio. So what does this patient have? Is this going to be a simple, straightforward thing, or do we need to ask some questions and get some more information? So let's review what we know so far. Number 1, there is airflow limitation. Can't say that enough here. FEV1 to FVC ratio is down. Got it. Okay. Number 2, there is hyperinflation and air trapping, and this is because we saw that increase in TLC plus the increase in the RV. Number 3, there was a decrease in the DLCO, so essentially there is a diffusion abnormality. Then, to make things even more complicated, there was a positive bronchodilator response, And so then you're starting to think, is there asthma here too? But if it's just asthma, then why is there this decreased DLCO? So I'm thinking emphysema, that causes airflow limitation. Pulmonary hypertension, that causes low DLCO. Could this be cor pulmonale? So to review, all right, we got asthma. That can cause airflow limitation, hyperinflation, and air trapping. So can emphysema. Check. So how can we figure this out? Well, we can ask the patient their history. So this is a little bit advanced, but I just want you guys to be able to apply this to a real life scenario. So what we do is we would make a differential diagnosis. So we would decide what we wanted to ask the patient based on what we thought might be going on. So I'm just going to put it all up here because we've gone over it a million times. So number one, the differential for the airflow limitation is essentially COPD versus asthma most of the time. Remember, COPD can have emphysema and bronchitis. The differential for an increased TLC and an increased RV is going to be essentially the same because the airflow limitation is what's causing the air trapping, leading to the increase in the RV and the TLC. Make sense? And then number three, the differential for a decrease in DLCO is it could be in this patient if they had emphysema, right, alveolar destruction, but also emphysema if it was causing destruction of the capillaries, and then cor pulmonale, which again is just sort of heart failure because of the lung problem, or unfortunately, and hopefully not the case, a totally separate reason for pulmonary hypertension, which would be unfortunate in this patient. So what would you ask? So if you're asking about emphysema, of course you want to take a smoking history. That is key. You could also ask about liver issues if you're thinking about alpha-1 antitrypsin, especially on a test. For asthma, you want to ask about a history of allergies, atopy, all that stuff we talked about today in lecture. So how do we figure it out? So for emphysema, it can be helpful to get a chest x-ray or a CT scan of the chest to look for the actual emphysema. For pulmonary hypertension, you can get a TTE that stands for a transthoracic echocardiogram, and that would be the same workup for the cor pulmonale as well, because at the end of the day, that's just right-sided heart failure. So what did our patient have? So she had a history of allergies and asthma when she was a child. She actually still has bed allergies, and she also has elevated inflammatory markers. When I say that, I mean things like eosinophils, like you talked about today in lecture. She also has a history of smoking, so that's not great for her. And her CT chest did show emphysema, which makes sense. And then her TTE, transthoracic echocardiogram, showed increased estimated pulmonary artery pressures. So this poor sweet lady has something we call COPD asthma overlap syndrome. Don't get scared. I don't think that's going to be on your test. She also appears to have cor pulmonale, probably from her underlying emphysema. All right, so I'm sure y'all are tired of hearing my voice, and I'm honestly tired too. But I just wanted to say a word on FVC. So FVC can be decreased in both restrictive and obstructive diseases, and that is important to know. So just to review, there's your tidal breath, deep breath in, deep breath out, and back to your tidal breathing. So remember this curve. So that's your tidal volume, right? And then next, you go breathe up to your inspiratory reserve volume. And then those two together make your inspiratory capacity. Then you breathe down your expiratory reserve volume. And then don't forget, there's that little residual volume guy down there. And then those two together, that's what makes up your FRC. And everybody together makes up your big TLC, right? And so where is the FVC, or the vital capacity? Well, the vital capacity is basically everything except that residual volume. So it would stand to reason that if your residual volume is increased, your FVC must be decreased. So in summary, I just want you guys to know that this is why you have to get lung volumes, and you can't just make a diagnosis on FVC alone. But I will say, once you have made the diagnosis, you can use the FVC on follow-up clinic visits to follow your patient's progression, because it's just a lot easier to measure spirometry than getting in a volume box. So in summary, patients can be complex. And hopefully on your exam, they're not going to have everything at once, but I just wanted to show you that in real life, they can have a lot going on. So just make sure you use the same method every time you read PFTs, and that way you're less likely to miss something. Number 3, you want to think about what history to ask them and what tests that you're going to order. And then lastly, FVC can be decreased in both restrictive and obstructive disease. However, it is not diagnostic. You got to get lung volumes. Oh my gosh, that was a lot. I'm tired, and I'm sure you guys are too. So thank you so much for putting up with me for however long this video was. And if you have any questions, as always, please feel free to email me at mkgreer@emory.edu. Thank you guys. Happy studying.